Welcome everyone. We're super excited to have everyone on tonight. We're going to be really covering some fantastic information about PPEs and about insurance and what you should be charging for. So we're super excited to have everyone on. I always want to start off by going over a little bit of the CE rules to make sure that everyone knows exactly what to do. It's very simple. Number one, make sure that you registered in your legal name. And what I mean by that is a name that's on your license. Also, each person needs to be on their own device watching this webinar because they are time stamped. So we'll know when you clocked in and when you clocked out. So it's really important to make sure if you want the complete hour to stay on for the complete hour. If you've signed in using your cell phone, if you push the login button, you're in good shape. However, if you've dialed in, we can't see your name. So what we will need you to do is to send me your name, the course that you're taking, and your telephone number. Again, that's your name, the course that you're taking, and your telephone number, and we will cross-reference that. You need to send that to practicecoaching@benco.com. And again, we'll give you that website again later, so don't panic. So with that being said, also you'll notice at the bottom there's some Q&A answers. We definitely want your input throughout the webinar. So please make sure that you use the Q&A. If for some reason that we don't get to answer your question live, we will make sure that Roy gets to all those questions and that we will send all those questions out to everyone who's on tonight's webinar. So again, just be patient, but please make sure you send us those questions and you will receive your answers. And with all of that being said, I would like to take the opportunity and time to introduce our sponsors tonight. Without these sponsors, we wouldn't be able to provide these amazing webinars. And so, you know, Care Credit's always been someone who's out there helping dentist offices. So, Dave, we really appreciate you tonight, and I would love for you to tell us a little bit about Care Credit and what Care Credit's doing for practices right now.
Well, thank you very much, Kay. We are very happy to sponsor events like this. And even in these times when we're getting together virtually, it's really a great opportunity to just connect with the dental community at large. So thank you very much for everything you've done. My name is Dave Hardy. I am a practice development manager with Care Credit. I live in the Philadelphia area and I cover parts of Pennsylvania and New Jersey. My information is there. Feel free to copy that down, and if you need to reach out to me, and later on I'll provide you with our phone number for provider services at the end if you need to reach out. So I'm going to ask kind of a rhetorical question: what's new? We know a lot is new, right, in the past couple months, and you all are dealing with a lot of different things, everything from curbside and parking lot check-ins to different phone conversations. You're all living in a virtual environment as we are tonight. There must be tons of protocol changes in your practices. You're dealing with financial concerns, both from the financial health of the practice, as well as the financial concerns of your patients who may be in different situations now. And communication has changed in so many ways. And so what I wanted to do is just share with you some of the things that we're hearing at Care Credit. We call on thousands of dental offices and practices just like yours across the country, and wanted to give you a little insight on what we're hearing, mostly so you don't feel like you're alone. But what we're hearing is some of the issues are training. A lot of people have new employees, or they've got employees in new roles, or they've got protocols that need to have some training behind them. And we know that's an issue for a lot of the practices. Practices are looking for ways to remain compliant and ways to minimize unnecessary contact. I think every year Webster's adds a new word to the dictionary, and this year it's going to be contactless because that's what everybody's looking for. They're also looking for ideas to make up for lost production. If you've been closed for 4, 6, 8, 10 weeks, you're going to need to see if you can recapture some of that production. And the key to that is just improving the acceptance of care in your practice. And offices are also looking for ways to increase the confidence of worried clients who have so many questions around this entire situation. So we'd like to see what we can do to help you with that. In terms of lost production, Care Credit now is offering 2 different promotions this summer to really help kickstart your practices and get your patients involved. Through August 31st, we are offering, and this is important, our 18-month promotion are deferred interest or no interest if paid in full within the promotional period at the same rate as our traditional 12 months. So we're allowing you to give your patients an extra 6 months to pay for their treatment, and that should really, really help you move them along. I'm thinking now 18 months from now is almost 2022. And if hopefully people will be able to see their way clear to, be paying the treatment off by then. There's nothing you have to do. This is already in place. Just talk about it in your practice and make sure you're offering that 18-month where it makes sense for you. There's no additional cost to the practice. It's still at that 12-month rate. Another thing we're doing, because we know a lot of your patients are in different situations than they were the last time you saw them. Maybe they've lost a job and lost insurance. Maybe they've burned through a lot of their savings that they would normally pay. Maybe they've maxed out their credit card. So you've got a lot of patients now who in the past never thought about financing, never asked about it. And so there's an opportunity there to start talking to them about financing and seeing if that 18 months might make a difference. So we're offering for new applicants who apply, get approved, and run a transaction of $200 or more between now, actually the beginning of May, so it's retroactive, through July 31st. If they do all those three things, they can go to our website, register, and they'll get a $50 gift card. I think the gift card is for Amazon or Starbucks. I think there may be one other. It's their choice. But another way to start the conversation about financing without actually starting with financing. These types of promotions have been very successful in the past, and we think this one will be a great way to give your patients a little bit of an extra boost as well. But those are kind of short-term things. On the long-term side, you're certainly going to want to be looking at increasing production. You're going to focus on those larger cases. Take a look at what your average ticket for a care credit transaction is, and you'll find it's probably higher than average. It's because we help you close some of those larger cases. Make the optimal treatment affordable. Break it down into lower monthly costs. That's going to help a big deal. And reduce the lower profit treatments if you have to. Obviously, take care of your patients, but look at those larger cases and try to get people into optimal care. You're going to want to try and get higher case acceptance. We had an office tell us in the past they were happy if we could help them close 5 or 6 of their big cases. That was good for them. And they said 5 or 6 out of 10. And now they want help closing all 10. They know that if they have 10 people in their chair that have cases, they want to make sure that they're getting those patients to move forward. And offering financing is a big help. So offer payment options and train your entire team in a case presentation, because everything's changed, and somebody who may not have spoken to your patients before about treatment or payment may be in a situation where they have to now because your staffing has changed. And then finally, you'll want to manage your cash flow. Get your payment at the time of service. We can help you with that. And avoid long-term AR, as this thing may drag on for a while. You don't want to be putting people in a position where they may not be able to help you. So in terms of going forward with optimal care, we have 4 suggestions. Make it clear. Make sure they understand what treatment you're presenting. Make it affordable by offering lower monthly payments. Make it easy to apply and to transact, and I'll talk about that in a minute. And make it part of every conversation. You don't want anybody walking out the door saying, well, let me think about it and I'll call you back, right? So those are some great ways to go forward, and we can help you with that. So Care Credit really wants to be out there helping with virtual trainings with your team and our team. We can do it via WebEx. We can do it via Microsoft Teams. We can do it over the phone, however best works for you. But because we cannot be in the field right now, and we know you probably don't want extra people knocking at your door anyway, but you may want some training, and we're happy to help you in a virtual situation. We can train new team members. We can train team members in new roles. Some of the topics we can cover are some of the basics, just transactions and applications, if you have somebody new running those now. If you want to look at care credit reporting to keep track of how well you're doing, we can train you in case presentation and increasing case acceptance and help you overcome objections, because we know financing is usually the biggest one. There are over 185 care credit practice development managers just like me all across the country. And I'll tell you from personal experience, we're dying to talk to people and give us a reason to put on a clean shirt every morning. So last year we made over 200,000 visits in person. We can't do that right now. So we're available for you virtually, and we've done a lot and they've been very successful. And we hope you will reach out to your CareCredit practice manager or practice specialist to see if we can set something up. From a contactless point of view, we've made a number of really good advances over the last couple months. The first thing is applications. Patients can apply for CareCredit anywhere. They don't have to do it in your office. Maybe they've done it that way for a long time. But you can put a custom apply link on your website. It's really easy, and then you can just tell your patients, go to our website, go to the patient page, and you'll be able to apply for CareCredit before you come in. We've also developed custom QR codes that you can post, whether it's inside your practice or even outside your practice. I've had offices tell me we tape these to the door, and patients can just come up to the door. They can scan that custom QR code with their phone, and it'll take them right to the CareCredit application. They don't have to see you. They don't have to talk to you about anything. And that QR code also comes with a custom URL, something similar to carecredit.com/go/ABC123. And that's a custom URL that you can text or email or even read over the phone to your patients. So they don't have to be in your office to apply. You get an instant approval notification, just like you would normally if they applied in the office. And the best part is there's no paperwork. You don't have to save a paper application. You don't have to get signatures. There's nothing for you to keep on file. This is completely contactless. And then moving on to a payment, we can do that for you contactlessly as well. So the payments are done online. The patient can pay remotely from anywhere. They can do it from their car, from their home, even from the chair right in your office. You will receive an email in real time telling you that the patient has gone online and made a payment. So you'll know the bill has been paid. Again, no receipts, no pens, no signing. This is completely contactless. The funds are deposited within 2 business days, just like they would be normally through an in-office transaction. So you don't have to worry about that. You're getting your money just like you would normally. And this can be done at carecredit.com. You can use that custom QR code that we talked about. And they can pay that way, or you can create a custom pay link and put that on your website. So whether it's a mom who may want to pay for her child's dentistry and she can't be there with them, or if they just want to pay from the car before they start, it's all available to be done online. So how do you make your patients more comfortable? It's communication. You let them know what to expect and what you've done. That's really what's going to make a difference. And we found from the offices we're working with, those who've been in constant communication about their opening procedures, what's going to be different, they're the ones that have had the most success. So I want to thank you today. There's a lot going on at CareCredit, and really want you to know that we're here to support you. We're here to help you with these changes that you're going through. And if there's anything we can do, please reach out. We'd love to see you. We'd love to talk to you. A great, toll-free number is 800-859-9975. That's our traditional provider services number. You should have it in your office. But if you can either reach out to me or reach out to provider services, we can certainly find the specialist who covers your area, and we're happy to help. So again, thank you to Benko. Thank you to Dr. Shelbourne. Thank you to everyone for your attention today, and we look forward to working with you. Thank you, and have a great night. Enjoy the presentation.
You did amazing. Thank you for all that great information. And I will say this, you did get some questions. So for those that sent Dave questions, we will send those to him to make sure that he can respond to you. So even though we didn't get to answer them live, we will make sure that you get those questions answered. I think there was 2 questions for you as you were doing your presentation. So we'll go back and make sure those are taken care of. So Roy, if you want to, Dave, if you want to stop sharing, let Roy start sharing. And while that's going on, I get to do the favorite part of what I absolutely love doing. I know that, Dave, you just talked about caring and taking care of your offices. Well, I will say this, the one thing at Benco is that we have a caring leadership team that I think understands the importance of communication. From the time that we've started this process until today, I don't think Chuck Cohen has missed one of these, and that's because he's a good communicator, and he definitely wants to know what our clients and our customers are thinking and how we can help them. And he's there, and when he hears something, he takes action, and that just shows what a strong leader he is. And I'm so lucky to be a part of this team. So with that being said, I would love to introduce the managing director of Benco Dental, Chuck Cohen.
Kay, thank you very much. This was great. And Kay, you're doing an awesome job, and thank you very much for the introduction. I got to tell you, this is a little bit of an unusual program because I learned as much from Dave Hardy's presentation as the sponsor. Usually it's like the sponsor, what's he have to say? I think it's tremendous how you guys at Care Credit have risen to the occasion and put together these new tools for every dental practice. Thank you very much. It's, at Benco Dental, we've got a few key partners out there. One is Care Credit, one is UPS, the guy who delivers the boxes. But honestly, without you guys at Care Credit, we know our customers don't get paid, then they can't pay us. So David, thank you very much for sharing, and thank you to all the folks at Care Credit who are taking care of the dental community. Making sure that dentists get paid for the work they do is so important, which of course brings us to the subject for tonight's program. I believe this is the third program that we've done with Dr. Roy. He is awesome. His personal story is compelling. He has visited prison. He has been on a journey that no one on this call wants to duplicate. I'm going to let him tell you his own story, and I'm also going to give you a preview to tell you that this will be one of the best webinars you attend, no matter how much you've done, no matter how many you've done. Everyone will walk away from tonight's program with real concrete information and tips and tricks that they can use to make sure that they code their insurance payments properly, they avoid prison, and they make sure they get paid for the work they do. So with that, I don't want to give away any part of Roy's story. He's going to share that with you directly. Roy, thank you for being here tonight, and thank you for all you do for Benco and the profession.
Chuck, my pleasure. It's always an honor to be speaking for Benco. You guys do a lot for the industry as well. In today's world, we're all in the same boat together, and we're trying to make the best of a very challenging situation. So thank you, Benco, for all you do. David, thank you for your representation of Care Credit. What David did not tell you, I'm the guy that's trying to keep you out of harm's way. And I need to let you know that if you are carrying balances in your practice and don't do outside financing, you are considered a lending institution by your state authorities. And more than likely, you're going to need to meet all the requirements that a bank does when you're forwarding money to your patients for them to be able to get their work done. If you're doing that in-house, you have to meet all the requirements necessary as if you were a bank lending money for a vehicle. You would have to have all the paperwork signed. Everything would need to be in order. And why in the world would you want to do that? Dentistry is hard enough. Why would you want to be a banker on top of being a dentist? So I'm just throwing it out there. Be careful about what you think you know, because I'm the guy that misunderstood. I thought that any mistakes I'd made, I could pay them back with no subsequent issues or repercussions. The best deal I ever got to settle in correcting the errors that I made was 3 years in prison and a restitution of $300,000. So yes, I did end up going to prison, and I learned a whole lot in the process about things that we should do, things that we shouldn't do. And today's world is it's a little scary. We go through life thinking, okay, everything's going to be fine. We don't have to worry about anything. But I think dentistry is a lot like this picture with the fisherman above the ice, dropping a line through the ice. And the next thing you know, there's this huge impending danger below you, a shark that's ready to bite. Now, when I graduated from dental school in 1981, literally you could make almost every mistake known to man and still be successful. In today's world, not so much. There's so many things that we need to be aware of, so many things that we need to keep in the forefront and be aware of, even though we've never been trained. And billing coding is one of those, and documentation is one of those things that we need to be aware of and need to put together systems in your practices so that you meet the requirements, so that you meet the standard of care. And we'll talk a little bit about that tonight. I have my contact information up. Would love for you to reach out if you have any additional questions after the seminar tonight. We'll try to leave some some time at the end to answer some questions. If you have them, love to be able to do that. I want you to leave with all the information you need to make sure that you understand in a way that you can implement the documentation and billing and coding process in a way that you meet the requirements. So one of the things that a lot of speakers do say is they don't want to scare you. I'm not that guy. I want to terrify you, but I also want to give you the tips and tools you need to be able to, if you implement the correct standards and the systems in your practice, you don't have to worry. You only have to worry if you let things fly, let things slide, you don't address them properly. So we'll be talking a little bit about that tonight, and I want to introduce you to my family. That's my wife and 3 children. Was released from prison in May of 2010, and the American Dental Association in 2010 was in Orlando, Florida. So we went to the ADA meeting. My son is a dentist. My wife is his office manager. And so we're a dental family. The other 2 are also in the medical field as well. So medicine is something near and dear to our hearts. But after being released from prison, this is at the not so scary Halloween party at Disney World. And, you know, we dressed up for that just to kind of play around. And I wanted to go as a convict, but my family wouldn't let me. They said it was too obvious. So they said I couldn't do that. But bottom line is, do we need to be fearful? We have to have a very active and real understanding of the dangers and some of the things that are out there, but we also need to put things in place so that we are able to answer those. So I want to focus on the fact that there are no secrets to success. It's a result of preparation, hard work, and learning from failure. And I've actually learned a lot from failure. I want you to learn from my failure. I want you to learn from my experience. I want to be the last dental professional who goes to prison for things that they didn't know or didn't understand. So we'll be sharing some of that information tonight. Like I said, we'll hope to be able to leave some time at the end so any questions you have that we might be able to answer. So the question of the hour, since things have changed dramatically in terms of our PPE, the expense that is associated with that, that's an overhead expense that we had not had in the past. How do we deal with those extra charges? So the American Dental Association has recommended that it be coded as a 1999, a D199, which is a non-specified preventive procedure. And like I said, the ADA made that recommendation. There have been some deltas who have come afterward and said, hey, by the way, that's an inappropriate code. That's not the right code to be able to use for that. So that being said, that is the code that is to be used to describe the extra PPE fee if you decide to charge that fee. And we'll talk a little bit about charging fees, the ins and outs and the positive and the negatives, but that's the code that you would apply when you're sending a claim to an insurance carrier to see if they might pay for an additional fee. And a lot of people will ask, what are insurance doing about paying for the PPE fees? And I can tell you that it is all over the board. There is many policies as there are insurance plans. So I can't convey to you tonight an answer to will they pay it or will they not pay it. I have no idea whether they will or not. Some do, some don't. Some insurance companies have adopted a policy that they will pay you an amount per visit. Sometimes it's $10, sometimes it's $8, but be aware the statement that was made is this is not going to be something that's ongoing. It's going to be a temporary thing. So is it changing? Yes. What I'm telling you today in this webinar, will it be different tomorrow? It very possibly could be. But for the standpoint of submitting the PPE fee to the insurance company, I would do that as a D1999. I would make a list of the additional things, supplies and techniques and things that you're having to do over and above what you used to have to do to meet the requirements. So there's a list for that. I would make a template so that that could be attached to the claim so that that would substantiate the reason for the additional fee. And here's a little trick I want you to also to implement. Many times when there's a non-specified code that is submitted on a claim form, that kicks the whole claim out, because a non-specified code is by report, and you have to specify what you did and why you're billing for that particular service. So rather than being auto-adjudicated, which means if you send a claim to an insurance carrier and there are no errors, it's auto-adjudicated, it's processed, and then the claim is then paid. If you have a non-specified code on a claim form, more than likely that's going to kick out the claim, which means it's going to need to be reviewed, which means subsequently it's going to delay that claim. So as a little hack I recommend to you, if you're charging a PPE fee, use the 199 and submit that on a separate claim. So, for example, the patient is coming in for a regular recare appointment. So they're having a periodic evaluation, they're having a prophylaxis, they may be having bite wing. All those items go on a claim form together, sent in separately, because that would be a list of services that typically would be auto-adjudicated. They go, and if they meet the requirements, there's not a limitation associated with, they're going to go ahead and pay that claim. But if you add the D1999, the non-specified PPE code that you're using with that, it's going to kick out the whole claim. So it will not be processed. It's going to have to be individually considered, and that's going to delay the claim. So little hack, I encourage you to go ahead and to send that in on a separate claim form so that you're going to avoid that. Also, something that's new and impending on the horizon is the fact that there have been complaints to government entities regarding the charging of that additional fee. And I can tell you there was actually a press release, the Consumer Advisory from the Maryland consumer area, that indicated that by charging for the PPE fee, the practice could be violating the Consumer Protection Act, and there can be repercussions as a result of it. All over the country, all different states have different opinions, way of looking at and weighing processing. Before I would implement the PPE fee, or if you have and want to know if there are maybe subsequent issues associated with charging that fee, I would call your dental association and say, I would ask the question, are you aware of any restrictions there may be in the state by submitting a PPE fee or charging an additional fee to our patients? So even though it's being widely charged, and like I said, I spend a lot of time on social media, and there have been a lot of discussions about the PPE charge. Patients sometimes push against it. They don't like to see it. So you have to weigh the good against the bad when you're charging the PPE fee. You have to determine whether it's right for your practice, whether it's going to be something that is going to bring in enough revenue to perhaps go over and above the patients you might lose as a result of it. So there again, you're going to need to think about how you're going to do that, how you're going to implement it, how you're going to communicate that. Otherwise, it could be very much more detrimental than it is positive. And understand that the target is moving. What's going to happen today, the rules and regulations or restrictions may change tomorrow, so be careful about that. As an alternate, I would recommend that you consider raising your fees. More than likely, if you're in network, they will disallow the PPO fee, the 1999. And if the insurance denies a claim, then you can charge the patient. If they disallow the claim, it means that they're going to not pay it, but you also can't bill the patient. So there again, you need to understand the contract that you sign. Are you obligated to follow those restrictions and limitations? You are. And if you have a number of PPO plans that you're in network with, it's going to be problematic. You're going to have that extra expense, and it's going to be hard to recoup that. If you don't have a whole lot of PPOs in your practice, rather than introducing an increased fee for the PPO charge, I would recommend that you look at your fee schedule and that you increase it in an amount that would help to cover and offset the expenses that have been caused and have been added as a result of that, the additional PPEs that you're going to need to be able to provide. So that's the skinny, the short about the PPE fee. Let's talk a little bit about teledentistry, because we are trying to reduce the face-to-face contact we have in the practices today more than ever before. And teledentistry, telemedicine, communicating via virtual platforms has become something that we're looking at as a possible way of having that interaction with the patient, perhaps being able to screen or assess them otherwise, and to go through a lot of the process that you would at a front desk and do it virtually. So in terms of teledentistry, there are codes that describe the teledentistry that was added a couple of years ago. So the 9995 and the 9996 codes were added. They're teledentistry codes. One is synchronous, the 9995. Synchronous teledentistry is when you have an interaction with the patient and it's live. You're talking to the patient live. You're having an interaction. You can ask questions. They can talk to you. You can banter back and forth. They can take pictures, send you, and it's in real time. So the patient is talking to you at the same time you're talking to the patient. That's synchronous. So that's described as 9995. Asynchronous is 9996, and that is any time that the patient has taped or videoed, or someone in your practice has taped or videoed an interview with a patient, and it's reviewed afterwards. So it's not live. There's a time lapse between the time it's actually recorded and the time it's reviewed. That's a 9995. Ultimately, the insurance carriers, none of them are paying for that. The ADA did a questionnaire, sent it to all the insurance carriers in the U.S., and all of them came back and said, no, we're not going to pay for that. So is it something that you can charge for? You can. There again, if you're in network, they're more than likely they're going to disallow that charge, so you're going to have to write it off. And to be honest with you, the interesting thing is that the insurance company, when the ADA asked them about teledentistry, they asked them, would they pay for a limited oral evaluation, 0140. And every one of the insurance companies except one said, yes, in fact, they would pay for a limited evaluation done virtually. However, you need to be aware that many states in the Dental Practice Act restrict the ability to be able to conduct an evaluation by a dentist remotely. So before you implement teledentistry in your practice, you need to understand the limitations, and I would make a call either to your state associations or to the Board of Dentistry and ask them, according to the Dental Practice Act, can our dentists do an evaluation virtually via telemedicine teledentistry? So if the board says, yes, you can, then that would be a way to do an evaluation prior to, and that would be a 0140. If you get the information that you need to be able to properly give that recommendation for that, what you've seen. So number one, is this in your scope of practice in your state? Can you use teledentistry to be able to do that? And call the state you're practicing in, but be aware that even if you're doing an evaluation with a patient, I live in the western part of Virginia. So I border very closely on Kentucky and Tennessee, and several of our patients actually lived in Kentucky or lived in Tennessee. Be aware if you are conducting teledentistry and you can do evaluations via teledentistry in your state, understand that if that patient is in another state, in Kentucky, and you're licensed in Virginia, or in Tennessee and you're licensed in Virginia, there's a very good possibility you need to be licensed in the state that the patient is in when you're conducting the teledentistry interview and conducting that evaluation. So be aware. You also need to understand that you need to meet the standard of care. Whether the patient comes into your practice or whether you're doing this virtually, that patient has to have what would be considered normal in your practice, a health history, informed consent. All that needs to be in place prior to. You also need to understand the malpractice insurance that you have may not cover teledentistry, telemedicine. The recommendations, the diagnoses you make virtually may not be covered under your malpractice. So the forms you need, the informed consent, the health histories, they need to meet the standard, whether that patient is in your presence or whether it's been done virtually. And finally, the government has actually reduced the restrictions as far as HIPAA. They say that in this world of COVID, they've reduced the limitations. They're not going to take actions against dental professionals if they communicate in a way that does not meet HIPAA standards. For example, FaceTime does not meet the standard. Can you communicate by FaceTime? Yes, now you can. However, once life gets back to a new normal and things switch back again, communicating that way by Zoom or by whatever FaceTime, whatever you're using, that will not meet the HIPAA requirements. So I encourage you, if you're thinking about looking at teledentistry, I would implement a platform that does meet the HIPAA standards now and use it. And there's one that has been in medicine for a number of years that most people use in medicine and do like it. It's Doxy, DOXY.me. I'd look at that platform. It's not an app. The patient would log in to this website, and it's encrypted in a way that meets the requirements, and that's a way that you would be able to meet the standards. So if you can't do an evaluation via teledentistry, what good is it? Well, it's a lot of good. You can interview the patient. You can clear out your health history review. You can do, there are a lot of things that you can do virtually via a virtual meeting that will streamline the process so that when the patient walks into your practice, they are directed directly back to the treatment room and they interact with nobody, which reduces the face-to-face contact. It's a way to be able to cut through all that rather than interviewing that patient, having that conversation through that front desk with the patient in front of you. You can do that virtually now. So I recommend you looking at that. There is a way to be able to code that, to bill for it, but understand things are changing, and there are a lot of states who are looking at the restrictions in the Dental Practice Act in lieu of what's going on to maybe increase that so more procedures can be done appropriately under state regulations in the states moving forward. So those are things to be able to look at. Let's talk a little bit about the clinical record and why it's so important. That clinical record is a document that will testify for you, will protect you, will justify a payment from an insurance carrier, will protect you from a malpractice claim, will keep you from being cited by the Board of Dentistry if it's done appropriately. About the record keeping, be defensive. If it's not in the clinical record, it was not seen, it was not said, it was not heard, it didn't need to be done, it wasn't done, it doesn't exist from a legal perspective. That is the one item, the one document that will testify for you loudly and strongly should you determine that you're going to put together a record that meets all the requirements. And I get a lot of questions about how do you do this? How do we, what does the template look like? And to be honest with you, it's hard to put together a universal template because so many practices are so different. The way it operates, it's very different, but there is a standard that I recommend that you look toward to construct your foundation when you put together your clinical records. And I encourage you to put together templates. Now, those templates should be flexible enough so that they accurately reflect that interaction with the patient, and they're customized to that patient and that interaction so that all of them are not the same. I have a problem with bringing in a huge amount of information in blocks because that when you bring those in for every patient, it looks like all your patients are the same, and our patients are not the same. Conditions are very much different. Things you focus on are very much different. So templates are good to a certain point, but they should be flexible enough so that we can make the appropriate entries and shift in a particular direction whenever the situation calls for it. So I encourage you to look at documentation via the acronym SOAP, SOAP notes. The S in SOAP stands for subjective. Subjective are those things that the patient share with you. That would be their health history, their dental history. That would be their background, their history of their condition. Anything that the patient tells you, their chief complaint, all those are subjective informations that you need to document when a patient shares, though, that information with you, because it goes together with the other parts to be able to diagnose and to treatment plan that patient. So there again, if it wasn't captured in that clinical record, it was not said. And the patient will have a different memory than you do. So be careful about documenting in the patient's words, especially chief complaints, so that it's accurate. It denotes what they said during that conversation. So subjective, those things that the patient share with you. The objective, those are the things that we as clinicians observe about the patients. So for a hygienist, that might be the perio chart. It might be the fact that radiographs were taken. The doctors, it would be your observations during the TMJ evaluations. It would be your observation during the caries assessment. It might be your observation about the patient's oral cancer condition, whether or not there's the things there. So those are the tests. Those are the things that you go through, the steps that you go through, the observations you make during that evaluation process that you note about the patient as they present. It might be their existing condition. It may be having to do with something that you've noted in that what you've observed with the patient. Then the assessment is the part where you put together what the patient's told you, the subjective, the things that you've observed and noted as a clinician. Those are the objective observations. And the assessment is ultimately putting everything together that you've observed and coming up with a diagnosis. Now, a lot of times I do see the notation with the subjective information. I do see a lot of notes regarding what the clinician has seen objectively. Unfortunately, dentistry does not, it should, but it doesn't base a lot on diagnosis. Now, do we diagnose during the process? We typically do, but what I see is we take it for granted that everybody should know that's the diagnosis without making a notation in the clinical record of that diagnosis, or if you don't know exactly, a differential diagnosis, the things that it might be. So for example, there's a whole new classification system with periodontal disease. I encourage you to go to the AAP if you're not familiar with the American Association of Periodontology and go through those different classifications, the changes that have been made, and the variables that are associated with. So for example, classic periodontal diagnosis would have three variables. It's either chronic or acute, which is one set of variables. It's generalized or localized, or it is chronic or, it's generalized, localized, mild, moderate, or severe. So a three-part periodontal diagnosis would be severe, generalized, chronic periodontal disease. And as far as gingivitis, there should be a diagnosis associated with that as well. And by the way, the new D4346 code, the scaling in the presence of, it actually has a diagnosis associated with moderate to severe generalized inflammation. So in order to justify the 4346, the scaling in the presence of moderate to severe inflammation, those words should be in that clinical record. The patient has been noted to have moderate, generalized inflammation, which would suggest that it might be appropriate to provide the 4346, the scaling in the presence of. So understand that things are changing even in the coding. It's tying more back to the diagnosis. Now, in medicine, all the reimbursement is based on the foundation of a diagnosis. Dentistry is not quite there yet. But ultimately, my friend Lori Owens, I think she's on the webinar tonight, is a guru when it comes to billing for medical. And before medical can be billed, you're going to have a diagnosis. We're not at that point yet, but if my crystal ball works the way I think it will, in dentistry, we're going to end up billing medical, and dental billing is going to go by the wayside. I think I'm going to live long enough to be able to see that happen, so it's not that far down the road. So be aware, if you're not familiar with and not doing some medical billing when it's appropriate, you need to look at that. And then the plan is the treatment plan, what you recommend to the patient to treat those things that you've assessed and diagnosed. So the treatment plan should be generated. And by the way, the patient should sign the treatment plan, and a copy of that should be maintained in the clinical record. Now, that signature on the treatment plan does not indicate that the patient is going to have the work done. The signature on the treatment plan, it should be communicated to the patient when they're signing that. This acknowledges that we've told you what we recommend to treat the disease that we have found and diagnosed in your mouth. It doesn't mean you are accepting it, doesn't mean you're moving forward through it, but it means that you've been made aware of and been given an opportunity to ask questions about what we've suggested. So SOAP is, in my opinion, one of the best foundations to be able to build your clinical records, your notes on. So ultimately, why is capturing all that information in your clinical record so important? I'll tell you a little story. It's a true story, actually. There was a practitioner who did not document very well, but had a very busy restorative practice. This doctor had a patient who had come in, needed a crown on tooth number 14. They entered that in the treatment plan, and that treatment plan went forward to the person who did the billing, and the person who did the billing went back at the clinical record, and there was no justification for the need for that crown. So the business person found the doctor and asked the doctor, Mrs. Smith was in this morning, you've diagnosed the need for a crown on tooth number 14. Can you tell me why that's necessary? So the doctor rattles it all off. Tooth number 14 had the mesiobuccal cusp was fractured off. It had a large existing alloy restoration that was surrounded by secondary decay, and 2/3 of the crown, or 2/3 of the tooth, was an amalgam. So the business person's writing like crazy to get all that information in, goes to the front, types all that information into the predetermination, and sends it off to the insurance carrier. The insurance carrier approves it because it's well documented in the information sent to the insurance company to justify the need for that crown. The crown's done, and this doctor is audited about 6 months after the fact. And this patient that we talked about was one of the patients that the audit consisted of. That patient was part of one of the patients that was audited. So the auditor has a copy of the claim and the information that supported the pre-D, and it's very well documented the need for the crown. Well, this doctor did not enter the information into the clinical record, and the business person had not been taught and given the authority to enter that information into the clinical record for the patient, so it wasn't there. So when the audit was conducted, the individual, the dentist who was doing the audit of this practice, had a copy of the claim, had a copy of the clinical record of the patient, and the documentation justifying the need for the crown that the insurance company got with the claim was not in the clinical record at all. So the clinical record is a legal document that actually justifies the need and needs to contain the necessary information to justify the treatment for that crown. So this triggered a larger audit. So they looked at the crowns in this practice for 24 patients. And of the 24 patients, they found that the documentation did not support the need for the crown in 12% of those cases. So the insurance company used the 12% and extrapolated. They multiplied the 12% by all the crowns they had paid for to this doctor over the course of 6 years, because the statute of limitation of fraud is 6 years. They multiplied 12% by all the payments they'd made for all the crowns, and this doctor had to return $112,000 to the insurance company because the crowns were not appropriately documented in the clinical record. So is documentation important? I surely hope so. So let's talk a little bit, we'll change gears here a little bit and talk a little bit about what I call magic words. You may have noticed when you call to follow up on visits regarding claims you've sent to the insurance carriers now, the person who is speaking on the other end of the phone, English is obviously not their first language, and it's hard to understand them, and it's hard for them to understand you. The bottom line is the people who are processing those claims are given a list of magic words associated with that service that you're providing. And if they see in the documentation for that service the magic word or words, then it justifies the service that you provided, and that claim will be approved. So, you know, it's as crazy as it sounds, and I'm not telling you to document anything that didn't happen, but be aware that these items need to be in the clinical record and need to be conveyed to the insurance company. Otherwise, there could be issues regarding payment. So let's talk about some of the services that we are submitting that need magic words attached to. So surgical extractions. There are two things that can elevate a simple extraction to the level of surgical. And I'll ask audiences a lot of times to tell me what that thing or those things that would elevate a regular extraction to a surgical extraction, what that might be. So I get answers like laying a flap or having to use suture. Actually, the two things that occur that can elevate a regular extraction to a surgical extraction, number one, you had to section the tooth, which means you have dilacerated roots or convergence in a way that you have to section the tooth into pieces to be able to get it out. So sectioning the tooth, number one, or number two, you had to remove bone. So one or both of those things needed to happen to have elevated a regular extraction to surgical. So that needs to be documented both in the clinical record as well as sent on the claim so that they understand. Scaling and root planing. To justify scaling and root planing, you need to have pocketing or attachment loss 4 millimeters or greater. Some want 5. It depends on the plan, what they limit. So you have to have attachment loss. Number two, bleeding on probing. So you need to make notation of all the bleeding points. And third, you need to have radiographic evidence of bone loss, and most insurance companies have a threshold of at least 10% or greater. So that information needs to accompany a claim for scaling and root planing in order for that person who is reviewing the claim to be able to approve it. Core buildups. Some insurance companies now, they feel it's been abused to the point where they're not going to pay for them. They say it's part of the crown preparation. They're not going to pay separately. But the magic word associated with core buildups that would help to justify the reimbursement for would be retention. If the core buildup were not placed, this tooth would not be able to retain a crown. That's the words that need to be in the clinical record. That's the judgment the dentist need to have made to justify that core buildup. Cracked tooth. You know, you can send pictures all day long, and a lot of times insurance companies will look at that and go, we're not going to pay for that. The magic word with a cracked tooth is discomfort or pain. So a tooth that's just cracked, most plans look at that and go, well, almost all teeth are cracked. So the patient's not suffering any kind of dire issue with it. So at this point, it's not generally necessary. However, if the patient is having pain associated with, whether that be hot or cold, unbiting or release, make sure that you make notation of the pain, the discomfort that patient is suffering, and that would help to increase the possibility of that being paid. Worn, abraded, or fractured teeth. So we see a lot of times with patients will present and the teeth are worn, just slap off, they're flat. And you think these teeth need to be restored, and more than likely they do. However, most plans will have a limitation where they don't pay for anything caused by parafunctional habits. So erosion, abrasion, abfraction, more than likely they're not going to pay for those because they are excluded in the plan. However, if the tooth is also fractured, when you're sending the claim or the pre-authorization, focus on the fact that the patient, that the tooth is fractured, not that it's worn. So the idea is focus on the fracture part. Palliative treatment, that would be a situation where a patient is having discomfort and you're doing something, some small thing to be able to get them out of discomfort. So it may be a chipped tooth that's rough, it's cutting their tongue. It may be a popcorn kernel that's irritating their gums. Some small thing that you do. So when you document that, make sure that you make a notation that the patient was having discomfort and what you did to relieve the discomfort. Understand that if you do other work at that same appointment, more than likely they're going to disallow the palliative treatment in addition to the definitive treatment you provided, because that's a limitation on the plan. Comprehensive periodontal evaluation. This is one I recommend you look at using. So if a patient has a periodontal condition or is at higher risk, a smoker, a pregnant lady, and you do the full mouth perio charting, that patient you can bill the 180 out on, and more than likely the reimbursement is going to be higher for that than a 120. If you don't ask for it, you won't get it, but the criteria for that, the patient has to have a periodontal issue, periodontal condition that have needed scaling and root planing or pocketing or some other periodontal issue. They won't have just inflammation, won't have just gingivitis, or the patient is at higher risk. And you need to make notation of the patient's diagnosis to establish the fact that they are a periodontal patient, or identify the risk factors that the patient has that would justify the 180. And like I said, it requires that you do a full periodontal charting. So consultations, there again, people are a little confused about billing out a consultation. Consultations are when a other licensed professional refers a patient into your practice. That is professional, that's considered a consultation. If a patient refers themselves, that's just a regular evaluation. And magic word with fluoride varnish, a lot of plans will remap that to a regular fluoride, unless some of them will pay for a fluoride varnish if the patient is at moderate or high caries risk. So it's important that you go ahead and do caries risk for your patients, especially if you're doing fluoride varnishes. And I would go to the ADA. California has one. The Pedodontic Association has a very good forms for establishing caries risk. Doesn't take very long to do that, but it's a way of being able to justify maybe that moving forward. So we'll talk a little bit about optional services before we get done. Optional services is when you provide work over and above what the insurance is going to pay for. So if you're doing Invisalign and they only pay for basic ortho, if you're doing a porcelain crown and they're only going to pay for a non-precious metal crown, it's considered an optional service by most insurance carriers. And most plans have what's considered the least expensive alternative benefit, which means they're going to pay for the least expensive thing that will replace that. So an optional service is what you provide the patient that's over and above that. So have a discussion with the patient, what that optional service is, have them sign an agreement. Make sure, number one, that the insurance company recognizes optional service. And if you'd like to have an article, I provide you an article as well as a template you can use to have the patient sign that you can use to be able to be paid for those services where you're actually giving the patient something optional over and above. And you need to understand that some insurance companies want you to submit a 999 code and explain what the optional service is, or they may want you just to add to the fee, and there again, that's a way of being able to figure out when you verify benefits for that patient. So attach that agreement that you've made with the patient to the claim that you send in so the insurance company knows that you're charging for the optional service, and then you can collect the difference between the optional service and the basic service that they're paying for. So we went through that like Grant through Richmond very quickly. Finally, I want you to think a little bit about what fees you should submit to the insurance carriers. The claim that you send
Hey, Roy,
in to the, yes, ma'am.
really quickly, let's just make sure your PowerPoint is still up because I don't see it. I just see your picture. So will you just check your PowerPoint for me and make sure it's still up, please?
It is up for me. Let me see. Hang on just a second. I'll check to see my Zoom if I'm still in. Oh, my share screen went off. Sorry.
Ah, that's what happened. I don't want
That would
anybody to
happen.
know that information.
Okay, here we go. Let me go back in again. Thanks. And if they want a copy of the presentation, if they've missed anything, they'll email me. I'll be happy to send them a copy.
It will go off. It will go out live. It will be put on Benco's Facebook page, and they can also get it there.
Okay, cool.
So we will make sure this is put out for everyone to see again. Thank you.
Beautiful, beautiful. Thank you. So always submit your full fee on the claim, and that is the fee that you've agreed with the patient to accept as payment in full. So if you're discounting your fees, for example, you're giving a 5% cash discount, you would put the discounted fee on the claim form. And with your PPOs, you've already agreed to a lower fee, but even in those cases, I recommend that you post your full fee. And there are 3 reasons for that. Number 1, insurance companies review claim submissions and average the fees that are charged. And if you're only charging what the insurance is going to pay, they're going to look at that and go, well, look, we're paying 100% of our fees. Why do we need to increase it? Number 2, if there are multiple insurances, you're not going to get benefit of perhaps when they coordinate an amount greater than the PPO fee. And you can keep that a greater amount if it's less than your full fee. And thirdly, you can't actually calculate accurately your write-offs for that plan. We encourage you that you do it every 3 to 6 months. You look at those write-offs, figure out how much you're giving away, and wonder and determine whether or not you can still afford to do that, especially in today's COVID world where your capacity may be reduced. You may look at eliminating some of those plans that you're having to write off a significant amount of money, and it'll make room for patients who are full fee or you're not in network with. So that's a way of being able to calculate that. 5 things never to say about insurance. Your insurance will. You never know what the insurance is going to do. They change from time to time. Even though you have a fairly clear idea of what they're going to do, will they surprise you from time to time? Yes. Do not own it. Don't tell the patient what the insurance company will do. We are going to send a pre-D. I never recommend sending a pre-D unless the insurance carrier says they're not going to pay unless you get a pre-D prior to, because the bottom of that pre-D, even when you get it back from the insurance company, it looks like it's approved. There's a disclaimer at the bottom that says this pre-D is no guarantee of payment. So they're telling you this is what it might pay. It may or may not. So you're not getting anything definitive. And that we will accept insurance payment as payment in full. It's considered unethical by the American Dental Association and illegal in most states if you write off copays and deductibles. You need to take every potential possibility of collecting those copays and payments. We'll bill your insurance and send you a statement. Try your best to appropriately calculate the patient's percentage prior to and collect before they leave. And if you're doing an optional service, make sure that you collect that prior to, because the patient may not remember that conversation they had where they've agreed to pay for the additional amount. So it's going to reduce a whole number of problems if you do that. And no, we don't take your insurance unless you don't take it. The insurance conversation, always be truthful, but I would start the conversation. If a patient says, do you take my insurance? I would say, be happy to answer that question. We'll be happy to work with you. But before we do talk about the insurance, about the money part, can I talk a little bit about you? Can I get to know more about you? Can I see if this might be a good fit? And I'd love to be able to see if we're going to be able to provide the care you need. And that opens up a conversation rather than just cutting it off with a yes or no. A way to be able, if you're looking at your fees and trying to figure out, okay, are our fees in line? Do we need to adjust those? Are we too high or too low? Or if a patient complains, you know, your fees are too high, I encourage you to go to Fair Health. So you can go to this website and you can enter the information about the procedures, and you can actually go in as a consumer. I think they limit the number of fees that you can get to 5 maybe per visit or per email, but you can go in and that, I think they roll that over maybe every 14 days so you can go in and get more, but it's a way of going in and verifying the fees in your area. You can type in your zip code and you can identify the treatments that you want to know what the fees are about. And like I said, these are fairly generous fees. So I encourage, if a patient pushes back about your fees and you know your fees are in line with Fair Health, I would tell them, well, I understand you're concerned, but let me give you a source. It is a consumer website that they do an independent study of fees in a particular area, and you can go look there and see where we fit in that group. So great way to be able to do that. So we rolled through these very rapidly. So wonder if there's any questions that people might have moving forward that I might be able to answer for them.
We do.
Do you have any questions, Ms. Kay?
Good job, Roy. We definitely have some questions. I don't know if you want to look at the ones and kind of see. I'll just start with one.
Yeah.
One of the questions is like on the soap notes, if they're not doing the regular exam, but they're doing like an occlusal filling procedure, how would you then fill in the soap notes?
So the objective would have been covered during the evaluation process. The subjective, if a patient told you something about the tooth that you were going to be able to restore, you might ask the question, have you had any discomfort with this tooth? We're going to go ahead and fill it today. And that would be something that would be the subjective part. The objective part, more than likely you made the objective observation during the evaluation, so you wouldn't have to cover that. That's already been covered. And the assessment would have been done as well, and the treatment plan would have been generated. So the plan would be, instead of the treatment plan, it would be what you provided. The P would be provided in this situation, so that would be the treatment that you provided during that procedure. And expanding a little bit, in today's COVID world, you're going to need to include what you did to screen the patient, so that if in the event that a patient might contract COVID 4 days after they came, or come down with COVID 4 or 7 days after their visit, and the patient could say, okay, I think I caught it at my dentist office, unless you document what you did. And to shortcut that, I would, in your practice, do an office protocol that would list everything that you did to meet the standard, whether that be, and I would make a notation just as you would for your blood pressure in the clinical record and the patient's temperature, and I would make a notation, followed guidelines, screening guidelines, and then per office policy, and in your office policy would have that so that people could go, okay, this is what you did to be able to provide that. So with a restorative procedure, if the subjective doesn't come into play, if the objective and the assessment have been done prior to, you don't have to duplicate that. So the plan or what you actually provided would be what you outlined in that clinical record for that restorative day. Great question.
Fantastic, good answer. And so the next one is, let's just say, so why do you think insurance codes will go away?
Oh, great question. Why do insurance companies do what they do? What's the bottom line? What's most important to an insurance carrier? Money. So in today's world, they have to maintain 2 separate divisions, 2 separate departments. They have to keep the dental separate from their medical. So they have 2 expenses. And what was added to the dental claim form in 2012? A box for diagnosis codes. And are insurance companies now requesting you submit the information to the medical carrier before dental carrier? Yes. It's all about the money. It's all about making sure that they do it most effective and efficiently. And that system is already in existence, and the ICD, they're actually adopting new, more and more codes that describe what we do in the dental world. So like I said, rather than having 2 separate tracks, having two separate ways to do it. We're all going to be under the same roof and be doing it the same way and using the medical standard moving forward. I go to the Code Maintenance Committee every year. The American Dental Association conducts that. That's where the code submissions, the recommendation for changes are submitted and reviewed. And the roaring underneath the table this year was modifiers and how to make it more robust. And I'm thinking, well, that already exists in the medical field. So between me and you and the fence post, the highest non-dues revenue for the American Dental Association is the code system that they own. So they're hanging on to it very, very strongly because they don't want to lose out on that revenue stream. But everything that I see from the insurance carriers and moving forward, it's moving in that direction. Great question. Mike, 5-10 years from now, Kay, you'll see me and go, you know, when you made that prediction, you can say I was either right or wrong.
I'm thinking that you're right, Roy. I'm backing you 100%. I think Laura and I both think that that's where we're headed. So this is a great question too. It says, you know, if you're doing a treatment plan and is the tooth chart considered part of that legal clinical record? For instance, you know, if you get audited and they conduct an audit, if you've made notes as the caries presented as a chart or filling recommendation on a treatment plan, will that be okay for an insurance carrier?
So if it's not evident either in a photograph or in a radiograph, if it's not obvious, then it's very important that you make a notation in the clinical record how it was diagnosed. So incipient decay on posterior teeth, that should be noted in the treatment plan, or most softwares, work with your software carrier. Most softwares will allow you to put a description or some item that's associated with that treatment plan item. You can go ahead and put it in there. But like I said, you need to screen that in a way that can't be modified. So sometimes those are deleted once the service is provided. So what I recommend as far as the diagnosis for charting, determining how the diagnosis was made. So doctors, generally you review the radiographs, correct? And if you're in the room with the assistant, with the hygienist can be making a note. Doctor reviewed radiographs and determined X, there was interproximal decay, the mesial MO was needed on tooth number 5. Then doctor, if you turn around, you sit down with a patient with an explorer, that person in the room is observing you, and they can make a notation, doctor observed with a explorer, whatever, occlusal restoration necessary on tooth number 14. So if you do that in the treatment plan and in the note in that area, yes, that will cover. And if anybody does review afterward how you came to that determination, and I recommend all new patients that you don't spend a lot of time in your software documenting the existing conditions. Take the radiographs that are necessary, and the FDA and the ADA put together a document in 2008 that updated in 2012, describes very succinctly what's necessary and how to go about determining. But make a notation in what you did, why you did it, and how you came about that determination. And regardless of how you make that notation, if it's in the clinical record, you're good. Great question.
That was a great question. So this next one's also really good. It says, let's see, more frequently now, I make a temporary removable partial for patients to wear while their endo implants is healing in the surrounding tooth. So they want to keep it stable to protect the graft and maintain the space. What code do I submit? Sure. It's like an Essex appliance, like a space maintainer, but I get rejected from insurances. So go ahead.
So if it's a space maintainer, if there's a periodontal issue, that would be an external stabilization. So you need to identify the periodontal condition on either side. Be aware if the insurance company reviews that, looks at that, and it's considered cosmetic or replacement of that tooth, more than likely the subsequent implant, bridge, or definitive replacement will be denied because of the frequency limitations. So there again, it's a little dicey. So if the insurance company does deem that as replacing that tooth, they may exclude a subsequent payment for that. So an Essex can be described as a stabilization, external, extra oral or extra tooth stabilization. It depends on the plan and depends on the periodontal condition either side. More than likely, they're going to disallow that. They're going to consider that part of the regular final restoration. But like I said, caveat is if they pay for that and it's considered a tooth replacement, it's going to kick out anything you do definitively. So be wary.
Thank you. So I'm going to finish with one more question, and then we'll just go over what's coming up, because I know you have some stuff coming up. And this question really does kind of cover a little bit about, I know one person wants to know your magic word. Just know, guys, any that we didn't get to live, we will make sure that everything gets answered. So you will get your answer, and everyone attending tonight will get a copy of the Q&A. So Roy has already made that promise. It just says, one of the ones I wanted to ask you was, it says, if you charge for PPE fees and the insurance doesn't pay you, do you have to charge the patient, or can you write it off?
If you have to be uniform, you have to treat everybody the same. So if you treat insurance patients different than your regular pay patients, then there could be an issue. Or if you only charge your insurance patients and you don't charge your other patients, that's considered discriminatory. So there again, it's all or nothing. Now, you can write it off on a per patient basis, but you need to justify in your clinical record why you've decided to write that off. So that's a little slippery slope. So ultimately, you have to treat all your patients the same. However, if there is a special condition or special circumstance with a single patient, you can make an exception, but make a notation of why that was justified.
Yeah, you definitely don't want to get caught, charging some patients and then writing some patients off. I think that's a big no-no from what I hear Roy saying. So, Roy, I want to thank you. That was fantastic. And I also, why don't we talk a little about your workshop that's coming up, Roy?
Oh, excited about that. That is a 2-day, 2-hour each deep dive with a huge workbook that's going to help support. We're going to, like I said, deep dive into some of the more difficult to understand and, navigating the waters. My goal is to have everybody maximize their legitimate reimbursement and keep them out of jail. So that's what we're going to do. We're going to give them the tips and tools that they leave absolutely nothing on the table, that they get everything paid for, but they don't hit the potholes. Just like talking about the situation with that Essex. If you get that Essex paid for and they say it's a tooth replacement, you're jeopardizing the subsequent. And there's a way to be able to do that, have a patient sign a form that requests you not to submit it, and HIPAA trumps everything else. So we'll be talking about all the ins and outs, give them the tools they need to be able to do that, to make sure that they leave nothing on the table.
Yeah, I've actually sat through Roy's workshop. So if you have someone in your office that is handling all of your insurance, it's a go. It will pay for itself. So the workshops are $125. However, it's 2 days. So it's on, and that covers both days. So it's going to be on August the 21st from 12 to 2 Eastern time, and August the 28th. Again, a fantastic workshop if you have someone in your office that needs help with insurance, or if you're getting a lot of denials and you need to understand better how to get paid. I would highly recommend this workshop.
Sure.
Roy really does spend a lot of time with everybody when he goes over it, and like the workbook that you received for that is amazing. So please consider joining Roy on his workshop. We are limiting the seats because he wants to be able to work with everyone. So if you're interested, you can purchase it at shop.benco. I think it's .com. I can't see it, but we will be able to give you all this information. And so with that being said, the next workshop that we have available for you guys is going to be Laura Owens. Now, and Roy just talked about Laura. So if you're doing a lot of procedures, and there are a lot of procedures that you can bill medical, this is another workshop that Laura's going to do a deep dive. If you are, there's so many things that you can do as far as with your health history. If a patient comes in, just last week, she helped an office that had a patient that had diabetes and high blood pressure and needed a partial. And clinically, we helped her get it paid through their medical insurance, which I thought was pretty phenomenal. So if you're interested in learning more about how you can use your patient's medical insurance, this is a great workshop, and it's going to be on July 17th and July 24th. Just let us know if you're interested. Again, this one's also limited to only 50 seats. And then Catherine Belt will be doing another workshop on communication and making sure that you are communicating well as a team. The message that you're delivering to your patients, and also telephone skills, like really and truly, how do we talk to our patients right now in this time, and how do we make our patients feel welcomed? So that workshop's going to be on September the 11th and the 18th. So if you're interested in that workshop, please let us know. And then again, we will always continue our free webinar series, because we definitely want to make sure that you stay up with that. So you can actually scan the QR code, and that will give you a list of our upcoming webinars. I think it's really, some of these upcoming webinars are phenomenal, and these speakers are doing this at no charge. So please make sure you scan that. And then we have an office manager panelist discussion that's going to be happening on Wednesday, June 24th from 1 to 2. And it's going to be talking about what the office managers are dealing with right now and how has it changed. We have 4 experts on here that have dealt with a lot of the situations and what they have found since they came back to their practice. And so that's going to be a fantastic panelist webinar on June 24th. And then Dr. Moorhead again will be doing the checklist, what has changed in the practice, and he actually gives out a lot of great information. So please make sure that you tune in for both of these free webinars. One again is on June 24th and the other one is on July 1st. If you have any questions, or if you have any questions for our speaker, Dave or Roy, you can also email us at practicecoaching@benco.com. And I know I said earlier that Chuck really does care about what you guys think. So please, if you want us, if there's things that you want to see or things that you want to know about, please don't hesitate to give us some feedback, because we really want to make sure we're taking care of you right now and giving you the things that you need to get your practices up and running. So with that said, I want to say thank you so much to Dave, and thank you to Roy. And again, great information. We really appreciate it. And thank you to all of our clients out there who are watching. So everyone have a great afternoon, and we'll see you next time. Bye, Roy. Bye, Dave.
Thank you, Mark.
Thank you.